what we're talking about is a range of questions about public service delivery. And I'd like to kick off by asking you how, in your view, we break out of what seems to us a very short-termist approach to addressing these issues. There are all kinds of reasons why we should be in a short-termist approach, but we've got to find a long-term way of thinking. How do you think we can get to that long-term way of thinking?
First thing I want to say is that a long-term approach to health and care is absolutely vital. We've known for decades that we've got an ageing population that will need a very different pattern of services, but because of our short-termism, we've not prepared well, and services and funding aren't well matched to that need. So the way we're doing it at the moment doesn't work. In healthcare, if you think about how healthcare is delivered, fundamentally it's about a skilled workforce. It takes more than 10 years to train a doctor, it takes years to train a nurse, to develop new roles, takes a long time as well. So you can't take a short-term approach and expect to have the skills and the systems and the ways of working that meet the needs of a changing population if you're always running your system focused on tomorrow, not even next week or next year, let alone that medium term. I was involved last year with a select committee that the House of Lords established to look at the future sustainability of our health and care system. And one of its key recommendations was that we set up an independent body, what in the shorthand might be referred to as an OBR for health, that didn't make decisions about the future of healthcare, given how important healthcare is to us all and that it's 10% of our GDP and publicly funded for most of that. It will always have to be a political responsibility for the health and care system. But that doesn't mean that we couldn't have much more independent analysis and scrutiny of those decisions, of the trends underpinning that, so that actually the public could hold politicians to account more, not just for whether or not they're delivering today, but whether actually they're making decisions that will put their health and care system on a sustainable footing for the long term.
That answer points to a core problem. The relationship between what academics and others are thinking, for example, in terms of looking to long-term perspective, and what politicians and government are actually doing in the short-term approach. Do you have any views about a better way of establishing a relationship between academics and policy making that would enable those kinds of understandings to get more fairly considered and more properly applied?
I think there is a challenge at the moment for politicians who are very focused on the short term, and so evidence and the complexity that evidence often brings, it very rarely tells you something simple that you need to do. I think there's perhaps less of an appetite for evidence. There's public distrust about experts, which doesn't help that. So arguing that a policy is well evidence-based isn't necessarily one that people feel will be a winning argument with the public. But also I actually think on politicians' side, one of the things that is very difficult for them is where evidence isn't presented in a way where the policy implications are clear. And very often also if you look at where most research effort is devoted, that's often not well aligned with actually some of these big challenges. So to give you an example of that, one of the things that we know is a major challenge for us is on our population health, how to deal with obesity, smoking and alcohol. There are lots of little studies about, say, which approach to weight management for an individual might be useful, but actually very little research looking at system-wide approaches to tackling obesity. So if you wanted to have an evidence-based approach to obesity, actually you'd find there were major gaps in that evidence because of the way that research funding, journals, etc., have approached that problem. And also it's much easier to do a piece of research which is on those smaller, more contained areas of work rather than the big, complex, system-wide interventions.
Very clear. There are lots of institutional and structural constraints on reforming public services. Some people argue that a more locally based approach, a more devolved approach, could make a difference to that rather than looking at it all in the national framework. What do you feel about that? Are you in favour of a more devolved approach?
I think we need to be very clear about whether we're devolving how care is provided or what care is provided. In terms of devolving how care is provided, I think there's a very strong argument for services to be rooted in the specifics of local communities. If you take things like social care, the provision of voluntary services, the nature of the community infrastructure in a place, how much of that is faith-based, how much of that is other types of services, or whether it's an area where there is very little support, that will have a huge impact on what sort of services you need to provide to older people and how you provide those. And no one in Whitehall can know that and design that. However, what we also see is that in a tax-funded system, the public view the N in the NHS very seriously and don't understand why in some parts of the country services should be different to others, and we see this with things like IVF for fertility, and people call this a postcode lottery, in a sense that we all pay our taxes. It's supposed to be a national health service. We want to make sure that everybody has access to a minimum standard of high quality care. And in social care, which was much more devolved historically, actually in the recent Care Act of 2014, there was a strong push again towards a sense of a national consistent entitlement.
I think that trade-off, that tension between a postcode lottery and local devolution is very, very hard.
Yeah.
Because if you do devolve, you very rapidly get to a state of affairs of getting services in one area which people in another part of the country don't get.
Yeah.
And as you rightly say, people are very intolerant of that thought.
It becomes very difficult as well. I was on the board of an NHS hospital until recently, and we had 2 local authorities that we served, and you almost had to ask patients in neighbouring beds, which local authority do you live in, because the support at home was a very different package. It's hard to run a hospital where you're actually having to adapt what you can do based on the postcode of the person that you're trying to send home. So there are no silver bullets and no easy answers to this. Services need to be rooted in their community, but actually that consistency of offer is something which absolutely is important to people, and many services will need a bigger footprint if they're specialised services than a sort of a local authority or other similar place.
Taking the discussion on health forward, one of the issues of the moment is the rise of what they call multimorbidities,
Yeah.
a set of different challenges that health has to deal with when people trying to reduce people's chance of dying early, or put in a more positive way, to increase their chance of living longer. How do you think the NHS can deal and adapt with that change?
I think the challenge of multimorbidity is one of the biggest challenges for our healthcare system and all healthcare systems going forward, because historically healthcare has been organised around body parts, or if we've moved away from body parts to individual conditions, diabetes or cancer. What we're seeing obviously is that increasingly people have 2, 3, 4 conditions. They're living with those long term. They're living with those where they as an individual want different things from their treatment depending on what's going on with their life, if they're in work, if they're caring for relatives, all those, and their own personal preferences around that. And so how we shift the healthcare system to be focused on the complexity then of the individual away from the body parts is really difficult. It's really difficult as well because we didn't focus on body parts for a random reason. We're focused on it because in many cases, high quality comes from specialisation. And as medicine is becoming ever more complicated, obviously to be able to stay on top of that evidence base to deploy the latest techniques, you need ever more specialisation to deliver high quality. But at the same time, if I have the most perfect bit of cancer care, but actually all of the rest of my care is not well coordinated with that and doesn't understand what I need and how to do follow-up, that won't actually deliver what I need as an individual. So this is a really difficult challenge. And obviously our existing workforce, most of whom will be our workforce in 10, 20 years' time, were all trained in very hyper-specialised areas. What we see with individuals then who want things like personal budgets, though, is that actually, however well we coordinate that care, people do find it really difficult to have so many people involved in their care.
Absolutely. So, I mean, that takes us on to the absolutely core point. The NHS isn't an institution, it's not a title, it's not a name. It's millions of people individually working to do their best to enhance the health of the people around them. And as you say, they do that in a whole variety of different ways. What do you think are the main challenges that we face in trying to enable those workers to work more effectively and better in the modern health world in order to deal with the multimorbidities, to deal with the local community issues and so on? How do you think we can overcome the historic way in which it's been and move it forward to a better ability of workers in the NHS to make a difference?
I think there are a couple of things which are really important. I think one of the things where I'm optimistic is that with technology, hopefully, if we can embrace new technology, in particular the power of new information technology, we can free up a lot of healthcare professionals' time from having to spend all their time acquiring knowledge and evidence and thinking about the technical task, to more time focused actually on the human task of helping individuals who have health needs to work their way through the system and be supported to live their lives healthily and focus on what they need. What that does, though, is shift very much what is it that makes someone a doctor or a nurse, because it shifts the balance slightly from technical skill, how good am I at cutting somebody open, to be very crude about it, which probably in the end a machine will be able to do quite a bit of, to a real focus on the people and the human skills and the ability to support people as they interact with ever more sophisticated technology and medical advance. But really the premium comes on the human skills of the people who work in the NHS.
So you think it's the human quality of the people who work there, plus technological capacity and skill to use the technology, particularly the information technology, which is more and more available?
Yes, and those two. And then thinking very clearly much more about the extent to which we are a paternalistic system that does things to people rather than an empowering and enabling system. So if you have long-term health problems, actually the person who provides most of your care is you. And so and probably the thing that will make most difference to the success of that care is your engagement with and understanding of that. So the system also needs to shift from an approach which does things to people to an approach which supports people to help them to care for themselves and access new technologies and official organisations where they need it.
Are there examples in other countries, or indeed particularly good examples in this country, which you could point to and say they're beginning to get this right, beginning to move in the right direction? Do you think there are lessons that we could generally be taking, either, as I say, from other countries or from particular parts of our system here?
So there's some very interesting work being going on in the Scandinavian countries for patients with Parkinson's disease, which has focused very heavily, started out with the specialists in the national teaching hospitals, realising that actually where patients were struggling, it wasn't typically because of issues in the specialist hospital. It was because actually the patient wasn't engaged properly in their care, and actually local health services weren't engaged well enough, and that actually a Parkinson's patient was most interested in their care and understood most about their symptoms. And so they worked very proactively with patient groups, with local health services, to try to turn the care model on its head and start with the patient. There's another example of nursing care in the Netherlands, again, really worked hard to break down all the silos of different tasks. Think again about what does the person, elderly person at home need? Right, let's not worry about what label different staff have. Let's just all think about how we do whatever that person needs to keep them well. So I think there are increasing examples of that. There's some fantastic work going on in Bromley by Bow, thinking very hard about the lives that people leave, the assets of the community, and how you mobilise those to support people to deliver care which enables them to support themselves and live well for much longer.
That's excellent. On the health and public services side, is there anything more, Anita, you'd like to add, that you'd like to emphasise?
I guess the only thing we haven't talked about is the join up with other public services.
When you're thinking about health, people don't live their lives and can look after their health alone. It relates to what happens in housing, what happens in other services. So in the housing field, do you think the current planning laws, which control how housing is built and where it's built, are right? Could it be changed? Should it be changed? How viable is it to change the planning regulations about what housing is built and how it's built?
So there are a lot of issues for housing and health and how the houses that we have, how high quality they are and things like insulation, etc., really important for our health. Security of housing, very, very important obviously for our mental health. Worries and anxieties about housing, very critical. Mobility, enforced house moves, a real challenge. But also obviously with the ageing of the population, there are a couple of other issues that are really important around housing. The extent to which in all of the regulations for housing, we build in houses that work well for people as they start to get mobility issues, as they start to get dementia, so that people don't get stuck in hospital or have to move into residential care homes because that's not well thought about. If you think now, increasing numbers of old people are at home with high needs are being cared for by a fellow old person. So there are basic things like the height of a toilet, so you don't have to lift somebody onto it, which if you're an 80-year-old looking after an 80-year-old, just becomes an impossible task. So these very practical things which design in from the beginning for people, housing that is well suited to those needs, which we know most of us will have. The other thing which I think is really important around housing is the extent to which we can build housing which reduces the risk of isolation. So social isolation is one of the big new risk factors for health. We know that we have an epidemic of isolation. People who are isolated are much more likely to have problems with their mental and physical health. And so if we can try to create housing which supports communities, which supports relationships between people, that will all help. The other thing that we see is that very often people get caught in a catch-22. There is some adapted housing which would be good for people, but often by the time people have realised that they need it, they're so far advanced that they can't actually get into it. So there are lots of issues around housing. The final issue that I would say is housing for the key workers. So obviously we have a big problem in our healthcare system of not being able to get enough nurses and retain those nurses, and the cost of living, in particular housing costs in many communities, is one of the big factors that leads nurses to leave the NHS.
You work in this area. How confident are you about the possibility to get change in the planning regime to reflect the kinds of demands you're very reasonably putting forward?
I think nationally it's been very difficult to get the full join up. I think one of the things that offers a potential way forward might be some of the devolution experiments that are going on. If you think about Greater Manchester or what's happening in the West Midlands, I think this is a conversation that people are really starting to see, where there is potential for real win-wins across services, and it's much more real, I guess, when it is local.
How important is social housing in all this? Recently, the proportion of people who own their own homes has declined. But obviously social housing can have real problems. For example, you mentioned earlier security of tenure and things of that kind. How can we incentivise both the building of social housing and the management of rented housing in a way that's fair to the tenant?
Yeah, so I think I would argue that security of tenure is a really important factor. Most of our public services and health is no different to this, want to provide continuity of care. And continuity of care is a really important factor in delivering high quality. But for most of our services are organised locally and geographically. And increasingly we're seeing that people are renting at very different stages of their life. So people always rented as a student, they often rented when they were a young adult. But it was much more typical then to get secure housing before you started a family. What we're seeing now, obviously, is that people are having families living in insecure housing, and it's very hard for them then to get continuity of services. It's very hard for their children who are moving school frequently. That creates health needs, that creates pressure points on families. So however we are to provide housing, clearly owner occupation is not the only way to give people secure housing. Other countries provide secure housing without having it just being owner occupation. But it's not just a house, it has to be a home that gives you access to a community and a route in a place. That is so important for services, and also actually that access to community support has an economic benefit as well. How many lone parents have to leave work because they're moved miles away from the friends and families that provided the help with the childcare that enabled them to keep the job? And there they were self-sustaining, and then they end up on benefits. That can't be in their interest and isn't actually in the taxpayers' interest either.
Tremendous.